So today we're going to be looking at the case of Marv Wilson. He's a 40-year-old who is coming to the office with chronic back pain. This patient has been on 30 milligrams of oxycodone 4 times a day. It's not specified as how long he's been on this medication, but we're going to kind of look into his case and see if there are any other therapeutic options for this patient at this time. So our patient today is 40-year-old Marv Wilson. He is a Caucasian male presenting to the outpatient clinic for a routine exam. Again, he's been on 30 milligrams of oxycodone 4 times a day for the past 8 months following a motor accident. As a passenger, he was wearing a seatbelt. Our office hasn't seen him personally since the accident, so it's the first time we're encountering some of his history and his chart here. So, quick past medical history. He does have a history of hypertension, type 2 diabetes, hyperlipidemia, and some mild anxiety. So, we'll take a further look to see what's going on with some of his social and family history. So, Mr. Wilson lives at home with 2 young children. He was excessive stress due to a recent divorce. He reports that he was previously married for about 10 years prior to this divorce. The patient is an independent contractor. All day long. He works between 40 and 50 hours a week. He doesn't do a ton of heavy lifting personally, but when he does, he says it definitely exacerbates his back pain. His diet is pre-cooked meals and fast food. This is due mainly to his demanding schedule as a contractor, and he's kind of always on the go, if you will. So we'll take a look at that diet, I guess, a little bit later on. He does have some family history of stroke on his father's side, in his father, and some depression on his mother. He couldn't elaborate too much on family history beyond his mother and father, but those are 2 things that we will also look into. Quite some time. Oxycodone is the one that I'm pretty concerned about just because it is a pretty powerful opioid, and he is on a fairly high dose. So he's got about 100 milligrams a day, and after some time, this is likely building a tolerance and potentially some dependence. So we don't have to keep an inhibitor, and that's he's been on this for about 4 years, and it's been doing a pretty good job at keeping his LBP within a healthy range. He's also taking metformin, 2,000 milligrams a day for his type 2 diabetes. Prescription for diazepam, 6 milligrams PO as needed for anxiety. He's not taking anything for the hyperlipidemia, and he does not have any known allergies. And just in the Wilson's compliance, as prescribed on a daily basis. He doesn't report any trouble with doing so, and he is aware of the purpose behind each one of his meds at this time. So upon initial inspection, our patient generally appears to be pretty healthy. He is 5'9", 208 pounds, and with those measurements, he has a BMI of 30.7, which puts him into a range for obesity, which is something that we will address in the therapeutic plan. His vital signs were 37.1 for a temp, 90 for a pulse, and his respirations were regular at 16 breaths per minute. His blood pressure is 134/78, and the patient reports that that's kind of a new baseline for him. His pain, he's rated at a 5 out of 10 on a pretty much general basis, but it is relieved with the medication that he is on, the oxycodone there. He reports that the pain is dull and constant. It's exacerbated upon sudden exertion. For example, if he's lifting something heavy at work, or if he kind of moves quickly in a way that his body isn't necessarily used to. He reports that the pain does not radiate. He reports no numbness, tingling, or urinary incontinence associated with his back pain. And aside from the pain, the patient indicated that he also often feels pretty drowsy and foggy, a little bit out of it, and also that he sometimes does have difficulty getting out of bed. And upon further questioning, he didn't indicate any explicit feelings of sadness or hopelessness, but that's something that we kind of want to look into a little bit more, being that depression does run in his family. Some assessment findings showed mild tenderness upon palpation, and this was mainly within the range of L3 and L5. Um, it looked that it appeared that the vertebral column was midline. He did have a limited range of motion when flexing and extending his back, but he did also have 5 out of 5 strength bilaterally in his lower extremities. Here too, you will see an image, and this was from an original MRI that was taken about 3 days after his original motor vehicle accident. And looking at this image, it does show normal findings. So at this point, in terms of his pain, we can't pin it on anything in particular musculoskeletally, but we will kind of look at some other factors to see what's going on here and see if we can better treat him than the current medication that he's on, that oxycodone. So after further assessment of Mr. Wilson and a little bit of a further interview, it's clear that his goal would ultimately be to come off this opioid that he's on. He feels that it is kind of interfering with his life and impacting his day-to-day in a little bit. So we'd like to, go ahead and look at some other options for him. What I would do is start gradually decreasing his dose of oxycodone, and this is per protocol, where fast tapering would be about 25 to 50% decrease every 3 days, and slow tapering would be about 10 to 20% decrease every 1 to 3 weeks. The fast tapering is definitely going to come with a more severe withdrawal symptoms most likely. So I would want to talk to him about that. But it's kind of dependent upon his needs and his lifestyle at this point. I would also recommend some sort of physical therapy or mindfulness meditation training, and this is just based on the fact that pain is it has many contributing factors. One of them definitely being mental, so I would want to encourage that he explores that realm a little bit. Also, some diet and lifestyle modifications. He is a little bit overweight right now, and he's aware of this fact. He's aware of the fact that his diet isn't where he wants it to be. So modifying this might take some kind of stress and off of his actual musculoskeletal system, and maybe alleviate some pain within his lumbar region. Also, some alternative treatments I would recommend would be massage, acupuncture, some manipulations, biofeedback. We could also talk about injection-based treatments, such as a cortisone shot. We could do 2 topical therapies, whether this be a cream or a patch, most likely lidocaine. And because he has been on this opioid for so long, I would probably consider a pharmacological treatment as well, just to make sure that he's getting that pain relief and that the pain is not interfering with his day-to-day life. So this could be NSAIDs, some ibuprofen. We could also look at some skeletal muscle relaxants if the pain was more of a nerve spasm. This could be in the form of Flexeril as the skeletal muscle relaxant. Could also look into a quote weaker synthetic opioid such as tramadol, which is some studies have shown that the potential effects for addiction and tolerance are less with this drug. And the drug that I do actually, or the medication I do actually want to focus on here would be duloxetine. And I'll get into this a little bit more, but I feel that as a I guess kind of second line defense at this point, being that he has tried the opioids, this may be a good fit for Mr. Wilson. Okay, so the medication that I've chosen to elaborate on further is duloxetine, and this is sold under the brand names Cymbalta and Irenca. It is an antidepressant, specifically an SSNRI, selective serotonin norepinephrine reuptake inhibitor. So, like that states, it's going to increase the amount of these neurotransmitters that are found within the synapse, and in turn, hopefully uplift or elevate mood in patients. And also, research has shown that these antidepressants also help with the alleviation of chronic pain. And there's actually a few studies in particular that have shown success of the use of this drug with chronic back pain in particular. So my thought process with this drug was that, due to the fact that Mr. Wilson has been on this kind of high dose of opioid for so long, it's likely that, eventually the effects of this drug have kind of maybe masked some of the symptoms of his depression, and vice versa. It's possible that his depression and kind of decreased mood state, if you will, is contributing to his pain. So what I'm trying to do is kind of go at this problem from a holistic standpoint and try to see if we can maybe alleviate his pain and also kind of address his potential depression here, because he himself does have some anxiety, and depression does run in his family and his mother. So I would want to kind of look into this further before actually getting him prescribed on this drug, but it's something that we could definitely talk about with this patient. So in particular, with duloxetine, our therapeutic goals in general would be to reduce pain, allow for an overall better tolerance of daily activities. This includes his work and his family life, because he does have 2 young kids at home. And again, we want this better tolerance without the increased risk for dependence, tolerance, and addiction that does come with the use of opioids. And again, too, we also want to address the potential depression and symptoms associated with that may be contributing to his chronic pain. So what I would do here is, if we were to move forward with this, start Mr. Wilson on a dose of 30 milligrams PO once a day for a week, and we would increase this dose to a target dose of about 60, or of definitely 60 milligrams PO once daily. And with this, we'd monitor and document for response in terms of pain relief and mood elevation. Alright, so some pharmacokinetics behind duloxetine. This medication has an elimination half-life of about 12 hours, and this ranges from about 8 to 17 hours. And most patients report that this drug remains effective pretty much throughout the whole day. So we can achieve steady-state plasma concentrations typically about 3 days post the start of dosing. This drug is eliminated mainly through the hepatic metabolism, and so this involves the P450 isosomes CYP2D6 and CYP1A2, and we'll get into a little bit more in terms of how this kind of affects the drug and some drug-to-drug interactions. It is well absorbed, binds mainly to the proteins found in human plasma. About 70% is excreted in the urine, and 20% is known to be excreted in the feces. And there are a number of special considerations regarding the pharmacokinetics surrounding this drug, and so we'll explore those a little bit further. So in terms of gender, age, and race, research shows there's no significant differences in terms of bioavailability surrounding duloxetine. However, smoking status is a factor, and it does contribute to a bit of a difference here. In particular, individuals with a history of smoking or individuals who currently smoke have demonstrated about or upwards of a 1/3 reduction in bioavailability of duloxetine. So that's something that we want to look into and assess in Mr. Wilson further. Additionally, renal insufficiency and hepatic insufficiency have been shown to significantly increase bioavailability of duloxetine. So again, we'd want to do a bit of a further assessment on Mr. Wilson to ensure that both of those systems are functioning properly and that there's no insufficiency or failure going on there. So duloxetine does present the potential of some adverse or in general side effects. Some of the more common ones would be dry mouth, drowsiness, dizziness, nausea, constipation, anorexia, and in turn weight loss, and increased diaphoresis. Some of the more less common or more serious ones would be syncope, vision changes, easy bruising, painful or difficult urination, seizure, manic episodes, severe skin reactions, right upper quadrant, pain, or jaundice. And so when looking at some of these vision changes, and that would also be associated with some kind of mental status changes as well, would be indicative of sodium imbalance, which is known to be a potential and more serious adverse effect associated with this medication. And then looking at kind of some of the other ones in this list, the right upper quadrant stomach pain and jaundice would be indicative of liver dysfunction. So those are something that we would definitely want to educate our patient on. In addition to that, again, make sure that his liver is functioning healthy on a healthy level, and kind of really have him look out for some of these more serious adverse effects. So some important drug-to-drug interactions to look out for here are with the MAOIs, and these are absolutely associated with duloxetine. Also here we have the CYP 1A2 inhibitors, and this will basically act to decrease the effectiveness of duloxetine. Also the CYP 2D6 inhibitors, which again will decrease the effects of duloxetine, and also the CYP2D6 metabolizers. So those metabolized by those isozymes, and that will actually decrease the effect of those or other drugs that are metabolized by that isozyme. We also have drugs that act on the CNS, and also serotonergic drugs. Specifically, we want to look out for serotonin syndrome, and in this case, I have a little image here, or in the corner on this slide, indicating some of the symptoms associated with serotonin syndrome. This can basically result from an excessive amount of serotonin, which could come as a result of duloxetine acting along with some of these drugs. Also, would want to avoid or be mindful of triptans. Also, the use of alcohol is going to have to be something that is looked at here, because alcohol would in fact have the potential to increase the risk for some hepatotoxicity and liver damage. Tobacco too, as I mentioned before, smoking does decrease the amount of duloxetine available, so we would want to make sure that this drug is effective in not it's effectiveness not being decreased by smoking. So with this patient, there would be a number of different teaching points that I'd want to focus on, and things to look out for. But in particular, I would want to kind of start with the fact that comes with virtually any antidepressant, and that is the potential for clinical worsening and suicide risk. So in addition to the fact that this drug will likely take about 2 to 4 weeks to become effective, I would want to educate my patient and have him be aware of any emergent signs and changes in mood, and in particular anxiety, agitation, any panic attacks, insomnia, aggressiveness, or any other unusual changes in behavior or worsening in depression. Additionally, I'd encourage him to be just aware and mindful of any excessive feelings of sadness or suicidal ideation. In addition to this, I would want to prepare him that this medication is known to cause an impairment in judgment, thinking, or motor skills, and being that he does work on a job site in conjunction with, probably some heavy machinery, I'd want him to be aware of this while taking this medication. In addition, I want to talk to my patient about the risk of orthostatic hypotension, and this is likely something that he's maybe not come into contact with before, given his age and general health, but something to be aware of, especially kind of during his period of initial use, and based on the fact that he is on an antihypertensive already. So I would kind of just want to give him a bit of a rundown on orthostatic hypotension and to be mindful of that risk.